You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 12th, 2022. This week, atrial fibrillation screening, sodium, potassium, blood pressure, and cardiovascular outcomes, drug prices, and cardio-respiratory fitness. First topic is AF screening. The journal JAMA Health Forum had a study on the cost-effectiveness of screening for AF using wearable devices. The New England Journal had a clinical decisions article centering on the question of whether to do AF screening in a 75-year-old man with hypertension and diabetes. An accomplished professor argued for AF screening, and a marginal podcast host argued against further AF screening. So let's talk about AF screening because it's coming up almost every week in clinic, and not just EP clinic, general cardiology clinic, emergency departments, and primary care clinics. The general idea of screening for disease comes up often on the TWIC podcast. But these have always been medically directed screening, meaning stuff that we order, like ECG monitors or colonoscopies, mammography, vascular screening, etc. The unique thing that's happening in AF screening now is that doctors are being shut out of the picture because of consumer devices like smartwatches. And increasingly, I'm seeing patients with screen-detected AFib that came not from a medical-grade monitor, but a consumer device. The article in JAMA was an economic evaluation using simulation methods of different strategies, and they considered 8 AF screening strategies, 6 of the 8 using consumer devices, and 2 used traditional methods such as like pulse palpation or a 12-lead ECG, and a control group was no screening. They then modeled multiple scenarios based on age to start screening, male versus female, daily wear time, and of course the cost of the device. And their primary outcome measure was the incremental cost effectiveness ratio, or the ICER. And ratios being fractions, this was US dollars divided by quality adjusted life years, or QALY. Secondary measures were stroke and bleeding. And they report that all 6 screening strategies using the wrist-worn devices were more effective than no screening. The screening model with the lowest quality of life year gain was the simple 12-lead ECG. The screening model with the best quality of life gain was a sequence of wrist-worn wearable pulse monitors, followed conditionally by wrist-worn wearable 1-lead ECGs, and then a confirmatory patch monitor. Now, strategies using the wrist-worn wearable device were associated with a reduction in stroke incidence by about 20 to 23 stroke events per 100,000 years, but an increase in major bleeding by about the same amount, 20 to 44 major bleeds per 100,000 years. Now, note the small numbers, 44 strokes and bleeds per 100,000 person years. And they found that the overall most cost-effective strategy was wrist-worn wearable pulse monitors, followed conditionally by wrist-worn 1-lead ECGs and then patch monitors. It was $57,895 per quality of life year gained. Now, the ICER of the most cost-effective strategy increased as the minimum age of the cohort decreased, starting with individuals aged 60 years or older. Now, that's not surprising because you are more likely to find AFib in older people, therefore it'll probably be more cost-effective. Also not surprising was that the ICER of the most cost-effective strategy increased as the cost of the wearable increased. Less expensive devices do better. And the authors concluded that, quote, this decision analytic model suggests that screening using wearable devices is cost-effective compared with either no screening or AF screening using traditional methods. And they were extremely careful about their limitations. It's a simulation, economic analysis, and models have to make assumptions. Their limitations paragraph was extremely laudable, and do read it. My problem, though, is way higher up than these specifics. Here, the assumptions are existentially flawed. Namely, how do you do a cost-efficacy analysis if there is not a shred of data showing that there is efficacy? I mean, the adequately powered loop trial, which used a far better AF detection device than a consumer wrist device and an always-on implantable loop recorder, failed to find a statistically significant reduction in stroke. There was no reduction in death, as well as a non-significant 26% increase in major bleeding in the screening arm. And so you might wonder, why are you covering an economic modeling paper? Well, I think we need to have a laser-like focus on any empirical assessment of consumer devices, which are shockingly devoid of outcomes data. The question is not whether AFib will be detected, it surely will. The question for patients and doctors alike is how best to handle this new information and whether these devices improve the health of the consumers or the makers of the device. And I don't exactly know, but I can say this, at least about our system. The more you come to know about all the uncertainties surrounding AFib, the more frightening it is to think about the millions of asymptomatic people who will now be exposed to a profit-driven healthcare system, where many, if not most clinicians in the U.S. are infected with an action bias to do stuff. The stress tests that lead to angiography and then stents, the echoes which lead to all manner of workups for shadows, the potential excess use of anticoagulation, and shockingly, the extra AFib ablations. All of the above without any data, except for loop and stroke stop, which strongly suggests that medical-grade AF screening is ineffective in improving health. My advice to 9 out of 10 smartwatch owners is to give it away. Now, I don't say this to patients, but I will leave this topic with a quote from the late Dr. Peter Skrabanek. He wrote, "The pursuit of health is a symptom of unhealth." All right, next topic, sodium, potassium, salt substitutes in cardiovascular outcomes. The journal Heart, which is a subsidiary journal of the BMJ, has published a meta-analysis of trials that look to assess the effects of salt substitutes on multiple outcomes, not just blood pressure, but cardiovascular outcomes. Sodium, potassium, blood pressure are obviously vitally important topics, but this is also a super interesting topic scientifically because salt substitutes do two things. One is they reduce sodium, but the other is they increase potassium intake. And sorting the effects of these two may be an important thing in informing dietary advice. Yet there's even more to this meta-analysis. That is the question of how generalizable was the massive 20,000 patient-strong SAS cluster randomized trial, SAS, S-A-S-S, which was published in New England Journal of Medicine last September. SAS was performed in rural China, so did it apply to other countries? Now, before I tell you about the meta-analysis, recall that the SAS trial randomized 600 villages in China to a 75-25 sodium-potassium salt substitute or to a control arm. And participants in the trial were enriched to be at high risk as they had a history of stroke or they had to be older than 60 with high blood pressure. The primary outcome was stroke, period, just stroke. Secondary outcomes were MACE. And this trial was hugely positive. The intervention arm had a statistically significant 14% reduction in stroke. The p-value was very low, and MACE and death were also reduced significantly. Here's the thing, though. Systolic blood pressure reductions were only modest at about 3 millimeters of mercury. And this study created a lot of buzz amongst the lower sodium proponents crowd. Trial discussant Dr. Brian Williams said this at the ESC when it was presented, quote, "Those who doubted the benefits of salt restriction for cardiovascular disease prevention were wrong. The debate stops here." Now, I'm not so sure. Let me use the Heart meta-analysis and an editorial in the European Heart Journal to explain. The authors from a number of countries found 21 trials that reported the effects of salt substitution on blood pressure or clinical outcomes. Now, 19 of the trials reported on blood pressure and 5 reported on clinical outcomes. The total number of participants in this meta-analysis was 32,000, but of course, the SAS contributed 20,000 patients. The overall reduction of systolic blood pressure was about 4.6 millimeters of mercury, And there was also clear protective effects of the salt substitutes on clinical outcomes like total mortality, CV death, and MACE. They were all significantly better with the salt substitute. And reductions in blood pressure were consistent across geography, no matter age, sex, history of hypertension, BMI, or any other baseline variables. The authors of the meta-analysis did a meta-regression, which is basically a correlation that attempts to account for the effects of different variables. And here, the meta-regression found that each 10% lower proportion of sodium in the salt substitute was associated with incrementally greater reductions in blood pressure. But here's the thing. Nearly all the salt substitutes had a sodium-potassium ratio, and as you went down in sodium, the general trend was to go higher in potassium. And in supplement figure 5, the plot of the studies looking at urinary sodium and urinary potassium finds that nearly every study but one shows a significant increase in potassium excretion, while most of the studies find no significant decrease in sodium excretion. It really makes you wonder whether it's the lower sodium intake or the boost in potassium that is providing the benefit. Okay, now I want to change gears and point you to an editorial in the European Heart Journal published this month. The first author is Professor Franz Messerli, and the senior author Salem Youssef himself. They make the provocative but persuasive case that the major reduction in outcomes seen in the SAS trial and in this meta-analysis stem mostly from increases in potassium intake. And of course, that means that efforts to highly restrict daily sodium may be misguided. Now, read their piece, but here's the gist. They analyzed the effects of salt substitution in SAS on 24-hour sodium and potassium excretion. They then compared those to the values of the average level of intake in the U.S. as determined from published NHANES data. So at baseline in SAS, the average sodium intake was very high at 4.3 grams per day. The potassium intake was very low at 1.4 grams per day. And so this is higher in sodium and lower in potassium than the average American intake, which is 3.6 grams daily of sodium and 2.1 grams of potassium. In the SAS active arm, the salt substitute arm, they were able to reduce sodium intake by only a modest 8%, from 4.3 to 3.9 grams. That's hardly anything, and 3.9 grams per day is still higher than the average American intake, which is high at 3.6. That's also double the recommended intake by the WHO and ESC standards and 3 times what AHA recommends. Now for the punchline. The SAS intervention, the salt substitute arm, increased potassium excretion by a much larger 57%, up from 1.4 grams to 2.2 grams, which gets them to the mean American intake of potassium. So Messerli and colleagues then point out that an 8% reduction in sodium would only reduce blood pressure by about 1 millimeter, while a 57% increase in potassium would be expected to reduce blood pressure by 3. Well, this makes sense because a potassium-deficient diet would also increase sodium reabsorption in the kidney, further exacerbating excess sodium intake. Therefore, they conclude it is highly likely that most, if not all, the benefits observed in SAS were due to the increase in potassium with a salt substitute. And importantly, the dietary sodium to potassium ratio decreased from 3.1 to 1.8 in the group that took the salt substitute. And the policy implications they get to is that SAS does not inform the controversy regarding the guideline for lower sodium diets, and surely there's no support for a 2 gram per day sodium intake, they write. And given the lack of hyperkalemia signal in the SAS trial or this recent meta-analysis from Heart, they find reassurance about the safety and efficacy of increasing potassium intake. Now finally, I want to do a little meta lesson on critical appraisal here. I interviewed the SAS PI, Dr. Bruce Neal, when the trial came out, and I did not press him on the absolute values of sodium and potassium intakes. And Messerli and colleagues showed that the importance of looking at what actually happens in a trial. Yes, the SAS intervention reduced sodium intake, but the absolute value of intake was still high. The bigger difference was in the absolute changes in potassium intake. 2 examples of how details matter in the interpretation of trials. Remember the REDUCE-IT trial of icosapent ethyl fish oil versus placebo in patients who had high triglycerides? Yes, the fish oil group reduced outcomes relative to the placebo group, but there were only modest reductions in triglyceride. Well, then you go to the placebo group and you find there are increases in lipid and inflammatory markers, suggesting strongly that at least a lot of the effect was due to placebo harm rather than active treatment benefit. Another example, in the original FAME trial, which found that FFR-guided PCI reduced outcomes relative to angiography-guided PCI. This launched FFR as an approach, but was it that FFR was special? Or was it the fact that far fewer PCIs were performed in the FFR group? So one way to interpret FAME is that FFR is great, but another way is that more PCI led to harm. Now, given that these were stable CAD patients, I find it likely that doing less PCI might have been the driver of benefit. The point is always to look at the details of what's actually happening in the trial. Okay, next topic, drug prices. Something super rare may happen this month, and sit down for this. The U.S. Congress may get together and actually do something to improve American healthcare. I can't believe it. But it's possible that a bill that allows Medicare to negotiate drug prices may pass, and it may lead to lower drug prices, if not directly, but also through indirect pressure on the makers of drugs. Now, I am nowhere near qualified to get into the policy weeds on this, but I know that in cardiology, affordability of evidence-based drugs is a serious problem in this country. Yes, I rail often about low-value care, and there is a lot of it out there. I mean, things like thrombolytics for acute stroke and icosapent But basic oral anticoagulants for AFib, sacubitril valsartan, and SGLT2 inhibitors for patients with heart failure with reduced ejection fraction are often unaffordable to those who could benefit most. So, my friends, allow me to be slightly optimistic about government doing something to help. The emphasis here, though, is on slightly optimistic. Final topic, fitness and exercise, even in older patients. Now, let's close by talking about cardio-respiratory fitness, or CRF. Now, first, my bias. I am an addicted endurance exerciser, mostly cycling at the moment, but also running and even swimming in past years. That said, though, I strongly suspect that exercise, as an intervention, gets short shrift amongst doctors. Two recent studies deserve a brief comment. First, Jack has published a neat little study using VA data. They looked at older veterans who had treadmill exercise tests, and they excluded people with heart disease. Now, VA data allows for making association between the number of METs achieved on a treadmill exercise test as a marker of CRF and death rates. And for every category of age, even septuagenarians and octogenarians, there was an inverse and graded association between fitness and death rates. The graded part really struck me as notable. Some fitness was better than low fitness, moderate fitness was better than low fitness, and high fitness was better than moderate. And the super fit showed no association with higher death rate. Of course, I know it's all observational, and those with high fitness also do other things to extend life. They eat better diet. There is also a real chance of reverse causality, meaning that the luck to live longer is also why you do better on a treadmill test. Now, before I say anything else, let me tell you about another cardiorespiratory fitness study. This is from the Adelaide group of Presh Sanders in Australia. They took patients with PAF or persistent AFib who had exercise testing and echoes. These patients had sinus rhythm and normal EF at the time, and they were able to complete the stress test. The group measured all manner of left atrial function from the echo, things that are way above my pay grade. But what they found was that cardiorespiratory fitness had strong associations with better left atrial function. For instance, less left atrial stiffness. Now, no, this paper does not establish cause and effect, but it is another step in understanding why normal exercisers have far less atrial fibrillation. My comments on both studies and on fitness. Of course, exercise data will surely be heavily observational. Yet, I still believe there is enough signal here to prescribe exercise as a prevention medicine, or an antiarrhythmic, or an antihypertensive. I tell patients that they should exercise every day that they eat, 15 to 30 minutes. Consider it like a pill. Now, compliance is low, of course, but when patients do it, the effects are amazing. Also, my friends, imagine a world where every clinician recommended such. Norms might change. And here's another thing. Though we don't have exercise RCTs, I bet this recommendation stands up to time better than most things we do in cardiology now. Surely a lot better than left atrial appendage occlusion procedures. And so that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, it really goes a long way to give us a rating. Write us even a 1 or 2 sentence review. These sorts of things help others find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.